symposium, so thanks for having me. So our head has got pressurized compartments, and sometimes those pressures cause problems. So the eye needs to have a pressure to keep it a nice round shape, and the brain has a pressure which is normally a bit lower, and when we stand up, it might drop to 0. And this sets up a pressure gradient across the optic disc at the back of the eye. So the eye pressure is pushing backwards and the brain pressure is pushing forward. And glaucoma is a common problem where the eye pressure is higher than the optic nerve pressure and it's pushing back and putting stress on the optic nerve, and that's how glaucoma damages your vision gradually. But the pressure of the eye on its own is not a very good predictor of glaucoma. There are eyes like this who have a healthy, strong optic nerve despite having a high pressure, and eyes like this who have a vulnerable, deteriorating, fragile optic nerve despite having a low pressure. And so that raises the idea that it's not just the pressure that matters, it's the susceptibility of the eye and how deformable and stretchy it is. And there's eyes like this that are remarkable because they're so very stretchy. This eye, when the pressure is high, has a very big optic nerve and a big cup and looks like glaucoma. And when the pressure drops after surgery, the optic nerve contracts and looks crowded and healthy. And it's still an area of debate and uncertainty whether having a stretchy eye or a stretchy optic nerve is a protective factor or a vulnerability factor when it comes to glaucoma. And that's because eyes that have more stretchy walls actually disperse the energy and have more of this hoop stress on the eye and less of the translaminar stress. We also see patients who have problems with brain pressure, and if the pressure in the head is too high, it pushes forward on the optic nerve and causes a swollen appearance to the optic nerve called papilledema. And the effect, the damage on the vision is very similar in papilledema and glaucoma. There are also pressures in the tissue around the eye and the optic nerve, the orbit. And there are conditions where you can have a negative pressure in the orbit, and that causes the eye to enlarge and you can become more short-sighted. Or conditions where the pressure around the eye is increased, and that can increase the eye pressure, but it doesn't necessarily cause more glaucoma, because when the pressure in the orbit increases from a hemorrhage or an injection or inflammation in the case of thyroid, the eye pressure and the orbit pressure and the optic nerve pressure all go up together. They're all correlated so tightly that the pressure gradients aren't really changing. And then there's a few unusual circumstances where it seems the optic nerve has its own pressure distinct from the brain. And when we zoom in on the anatomy of the optic canal, there are discontinuities between the fluid compartment in the brain and the fluid compartment around the optic nerve. And these can act as a valve so that when we stand up, if the brain pressure drops below 0, it traps some fluid behind the eye so that our eyes don't sink back when we stand up. And there are some cases like this woman who has a raised pressure in her head, all the classical findings and symptoms of having a raised pressure in her head, but she's never had swollen optic nerves. Or this woman who has the same problem but has only had swelling in one optic nerve, which makes you think there is something about their anatomy that protects the eye from getting a swollen optic nerve. So I've been having fun kind of exploring the relationships between these different pressures. This study involves tipping people upside down. The main achievement is coming up with a funny acronym. I did not receive any funding from the Space Force or Starfleet Command. The idea is that at the back of the eye, we can see the little retinal vein pulsing, and if the pulsations increase, it tells us that the eye pressure is higher than the brain pressure. If the pulsations decrease, it tells us that the brain pressure is increased more than the eye pressure. And so the main innovation was to lift this tippy table up off the ground so that we could scan the eye while people were upside down. And when you tip backwards, the eye pressure, shown here on the Y, doesn't increase very much until you get to supine, lying flat on your back. And then as soon as your head goes down, the pressure responds like a fluid column, like a like a simple physical property, and the radius of that sine curve, the length of the fluid column, is roughly the length from your eye to your left atrium in your heart. So that implies that the veins from the heart to the eye are acting like a fluid column, and that there is regulation of the eye pressure when we're sitting up, but it sort of behaves like a very basic physical property when we're head down. And we can measure lots of things when people are upside down. This is the eye pressure sitting and inverted, and it increases in everybody and stays up while we're inverted. And then this is the blood pressure in the kind of maroon color. And if you measure it up at eye level by raising the blood pressure cuff up here, then the arterial pressure does increase a bit when you tip upside down. And so the ocular perfusion pressure, the blue one, seems to increase a bit, and we see a corresponding constriction of the blood vessels in the eye, which is auto-regulation of the blood vessels in the eye. And we can measure lots of structures in quite high resolution in the back of the eye with the amazing OCT scanner. And the main finding is that when you tip upside down, sorry, I'll go back a little. When you tip upside down, this thick vascular layer called the choroid underneath the retina expands because the venous pressure has gone up. But I think the most interesting findings are these videos. So this is the same eye sitting and upside down, and you can see that there's a pulse here in the vein, and there's a pulse here. So the eye pressure has gone from about 20 to about 40, and yet the pulsation hasn't really changed, and that indicates that the pressure in the eye and the pressure in the brain have gone up to a similar extent. And this is another eye where there's a little bit of a pulse in this vein, and it's, so maybe, you know, a slight pulse in these veins, which is still present to a small extent despite a large change in the eye pressure. And so most of these eyes had a horizontal line indicating there was no change to the pulses in the veins when people went upside down, although there were some whose pulsations increased and some whose pulsations decreased. And this is an example of somebody who had a pulse when they were sitting up, and it went away. And that implies that as the eye pressure went up, their head pressure went up even more. And there were other eyes, other people, where they had a little bit of a pulse that got much more pronounced as the eye pressure increased with inversion. And so that implies for those people that the intracranial pressure did not increase as much as their intraocular pressure did. Anyway, I've been enjoying that. This is my summary, that when you tip people upside down, the eye pressure doubles. So the pressure on the eye, the stress on the whole globe definitely increases. But in most people, the pressure across the optic nerve does not seem to be changing. And so that's a new and interesting model for stress on the optic nerve that is quite easy to achieve by tipping people upside down. This is the bit that I've been enjoying working with Sam and the Mātai team about. These goggles were developed by a glaucoma specialist in South Dakota called John Vidal. And he had the idea that if you put these suction cup goggles around the bones and create a negative pressure in the orbit, that expands the orbital tissue, the eye grows, and the pressure in the eye decreases, at least while you apply that negative pressure. And so we've had fun, as Sam suggested, putting these goggles on and putting people in the MRI scanner with positive and negative pressures on their optic nerves, on their orbits. And the goal here is to see whether we'll see which tissues of the eye, the optic nerve, and the other orbital tissues, which ones are most deformable when we apply an external pressure to them. And I don't have quantitative data to show you, so I'm really looking forward to digging into these images and working out the precise volume changes. But the other bit that has been quite exciting is looking at the tiny movements that Sam and her team have developed and innovated. These movements called amplified MRI, where you take the small wriggly pulsing movements that happen with each heartbeat and amplify them so that you can see them. And you can see there's all sorts of interesting stuff going on, but none of us really have the language or the or the experience to be able to interpret them yet. So we're really in uncharted territory, and it's really sort of a creative and exciting time as a scientist to look into new things. So optic nerve diseases are sometimes related to the pressure, but more specifically, they're related to the gradients of pressure and the extent that those pressure gradients deform and strain the tissue. Posture and gravity influence the pressure compartments of the head differently, and that seems to be different in different people. So that's all new and interesting stuff that I'm enjoying getting into. And can't wait to find out what we find out with our Mātai project. So there's my acknowledgements, and thanks for your attention. See you.